Hello and thank you for the opportunity to present. My name is Eric Ponce and I'm a Master Public Health candidate with a background in pharmacy, cardiology, and public health. Today I'll walk you through a proposed research study that examines two very different approaches to reducing cardiovascular risk in adults with obesity but no diabetes. Glucagon-like peptide 1 receptor agonists and structured lifestyle interventions. Obesity affects over 42% of adults in the U.S. and significantly increases the risk of cardiovascular disease, stroke, and premature death. As the crisis grows, we need treatments that are not only effective, but sustainable and equitable. GLP-1 receptor agonists have entered the spotlight as promising new treatment for weight loss and possibly for reducing cardiovascular risk. But how do they compare to traditional structured lifestyle change programs involving diet and exercise, especially in adults without diabetes? That's where this study comes in. Here's the challenge. Most of the existing research on GLP-1 receptor agonists focuses on people with diabetes. In adults without diabetes, especially those with obesity, we don't yet know how these drugs perform in terms of long-term cardiovascular outcomes, nor do we have a robust comparisons to lifestyle programs. This gap limits our ability to make informed, cost-effective, and equitable treatment decisions. This research aims to fill that gap with real-world comparative evidence. At the heart of this study is one key question. In adults with obesity and no diabetes, are GLP-1 receptor agonists more effective than structured lifestyle interventions at reducing major adverse cardiovascular events over 2 years? Answering this could reshape how we treat a huge segment of the population and guide future health policy. Filling this gap could help optimize clinical decision-making and inform guidelines on the most effective and efficient way to reduce major cardiovascular events in people with obesity. This is especially urgent given the high cost of pharmacological interventions and the need to find methods of reducing the burden on our healthcare system. I bring a unique set of qualifications to this project. I've worked for over 5 years as a certified pharmacy technician, which gave me a first-hand view of the barriers people face in accessing care and medications. I have concurrently worked as an electrocardiogram technician, giving me a first-hand view of how intense and damaging major adverse cardiac events are on the body. Alongside my clinical experience, I have experience working on 3 quantitative and 1 qualitative research studies, including a meta-analysis, modeling study using a Monte Carlo method, a randomized control trial, and a focus group. As a Master Public Health candidate interested in pursuing a career in pharmacoepidemiology, I'm trained in research design, biostatistics, and health equity. This blend of clinical insight and academic rigor makes me well positioned to lead this research and translate it into action. This will be a 2-year prospective cohort study. We'll enroll adults 18 to 65 with a body mass index of 30 or higher who do not have diabetes. Participants will fall into one of 2 groups: those prescribed a GLP-1 receptor agonist such as Zepbound, Mounjaro, or Wegovy, and those participating in a structured evidence-based lifestyle intervention program involving diet and exercise. We'll track cardiovascular outcomes, specifically major adverse cardiovascular events or MACE, using both electronic health records and laboratory testing to evaluate cardiac function and health. Our data will come from electronic health records supplemented by laboratory testing such as blood panels and EKGs to evaluate cardiac function and health, collected every 6 months. Alongside the clinical data, we will interview the patient at each follow-up appointment to discuss their thoughts on the intervention and address questions or concerns. We'll analyze the clinical data using survival analyses techniques such as Kaplan-Meier curves and Cox proportional hazards models to compare time to event. For the qualitative data, we will use thematic analysis to identify common themes among the patients of both groups. We'll also stratify the results by key demographics like race, gender, socioeconomic status, which is critical for understanding potential disparities in treatment effects. If successful, this study could directly inform clinical guidelines and public health strategy. we'll be able to identify not only which intervention is more effective, but also which offers the best value for healthcare systems and patients. This is especially important as GLP-1 medications come with high costs, which raises questions about access and equity. By filling this evidence gap, we can help decision makers prioritize the right treatment for the right patient. We're committed to making sure our findings drive real change. In addition to publishing in peer-reviewed journals like JAMA, Cardiology, and Obesity, we'll present at national conferences including the American Public Health Association and American Heart Association. We'll also produce policy briefs tailored for public payers like Medicaid and develop call to action briefs for pharmacy benefits managers such as CVS Caremark, Optima Rex, Aetna, and others. The goal is to ensure this research isn't just academic, it's actionable. To make this research possible, I'm requesting funding to cover costs associated with the implementation and continued support of this research. This investment will support a scientifically sound and socially impactful study that addresses one of the most urgent issues in modern healthcare. Thank you for your time and consideration.